The patient safety problem is huge. It exists everywhere. A study in the United States suggests that medical errors kill more people each year than do road traffic accidents, workplace accidents, and AIDS.
I don't think there's any question it's a serious problem. We estimate in the United States at least 1 million preventable injuries a year, about 100,000 preventable deaths a year.
Trying to face up to this as a public health problem, like a disease, like road accidents, like tuberculosis, malaria, any sort of major public health problem, and to get that addressed on a sort of systematic way by policymakers or by health service managers, that's also a very tough battle.
When I've talked to victims' families, it's often a story of confusion. They're called to the hospital in the middle of the night, they're told that a serious situation's developed, they're not necessarily told what it is initially, and then when the worst news is broken to them, that their family member has died, often there are conflicting accounts as to what's happened.
On the face of it, unsafe healthcare seems like a contradiction in terms. Health and safety are two sides of the same coin. They seem synonymous. And healthcare professionals have problems understanding it too. If your business is to reduce the harm caused by injury and sickness, then it's reasonable to assume that safety is something that just emerges as a natural product of that process. But it isn't. Safety is something very different. Safety is something that has to be managed, that has to be planned for, that has to be trained for, just like any other medical activity.
Typically the error rates will come through as maybe 2, 3, 5%. I think what is important to remember is that each patient during their hospital stay will probably have 10 or 20 prescriptions written and will receive maybe up to 100 doses. So they quite quickly multiply up so that each patient is at some risk of being subject to an error.
The effects of error can be catastrophic. Ask any healthcare professional what they fear most, and the answer usually concerns some kind of catastrophic human failure.
These headlines, these sad human stories, are just the public face of the patient safety problem. They're but the tip of the iceberg. So how big is the problem? Well, there have been studies now carried out in Australia, New Zealand, Denmark, and in the United Kingdom. And all of these come up with very much the same sort of number. Something like 10% of patients entering hospital are likely to be harmed, injured, or even killed by medical error. 10% is truly a staggering number. Let's try to imagine what it would be like if 10 out of every 100 aircraft passengers were to be harmed, injured, or even killed. Aviation would soon go out of fashion. The reality in aviation is that the chances are much better than 1 in a million that any passenger would be involved in a serious accident. However, such comparisons are inappropriate. Doctors and nurses are not especially reckless or error-prone. Rather, it's their work that's highly provoking of error, while the people they work on are extremely vulnerable, being sick or injured, and thus more likely to suffer harm. The probability of going wrong is highly dependent on what you're doing. In a 12-hour flight, for example, an airline pilot may physically handle the controls for less than half an hour. But doctors and nurses are performing a wide range of hands-on activities nearly all the time. The more you do, the more opportunity there is to make an error. Human nature being what it is, widespread concerns about safety tend to be sparked off by some horrendous public accident. But healthcare has had no dramatic wake-up call. Although the victims of medical error are very numerous, they tend to be buried quietly, one by one, and in many different locations.
If patient safety were a disease, it would have been at the top of our agenda long ago. NPSA.
The costs to the National Health Service of extra days as the result of medical error amount to something like £2 billion a year. The costs of hospital-acquired infections amount to £1 billion a year.
We put a resolution to the World Health Assembly, that's the annual meeting of all 192 countries of the world, calling upon countries to take patient safety seriously, to take action and put in programs in their own countries. We've received a terrific response. It's led to the establishment of a World Alliance for Patient Safety, and out of the 192 countries in the World Health Organization, over 150 have asked for help, support, or committed themselves to action, and that's unprecedented. So this is a global challenge.
The Harvard Medical Practice Study that showed the enormous extent of the patient safety problem in the United States was published in 1991. So why is it now that patient safety gets top billing in healthcare conferences? Why is it now that prestigious journals are devoting entire issues to the question of medical error? It's very hard to date exactly the year in which the transition occurred, but I think 2000 is as good a date as any. That was the year in which the Institute of Medicine published their enormously influential report called "To Err is Human."
And the shocking number was 44 to 98,000 people dying as a result of medical error every year.
It was in March of 2000 that the British Medical Journal devoted an entire issue to the question of medical error. In the same year, the Department of Health published the findings of an expert committee called An Organisation with a Memory, again devoted entirely to the issue of patient safety.
Quality of patient care is probably the most important element of healthcare provision, and safety is at the very heart of quality. So it has a very high priority. It's something that we have to get right, and we have to start making progress on it very, very quickly now that we've identified the size of the problem.
For so long, we have accepted levels of harm that are so far exceed what any other industry has accepted as normal. That it astonishes anybody who's not inside the medical field.
You tend to find that the same things happen over and over again. It's confusion between different pharmaceutical forms of the same medicine. It's confusion between similar packaging. It's where there's unfamiliar drugs with a similar name to a familiar drug. There's a real tendency for those to be given.
It's really important also to do safety checks for new medicine products. We've had a case recently where two like-sounding vaccine products, Repivax and Revaxis, have been mistaken for one another, and 93 children in a school were given the wrong vaccine.
The full story becomes apparent 2 or 3 days down the line, and sitting through talking to people for, say, 2 hours about an operation that's sort of changed every aspect of their lives. They're in chronic pain, their marriage may have broken up, their sexual life is ruined, they can't work, these kind of things. That's what sticks in your mind.
One of the most tragic areas in human terms is when a child loses their life due to a medical error. It doesn't happen very often, but when it does happen due to, say, a mix-up in medication or the wrong dose of medicine being given, it's absolutely devastating for the family that lose a precious child, but also for the clinical team who probably never recover from the harrowing experience of being involved in causing the death of a child.
The post-traumatic symptoms, people having nightmares about the hospitals, being unable to go near a hospital, the deaths, all of these kind of things. That's what patient safety is really about.
The aftermath of an accident of this sort in healthcare is just as important as dealing with the aftermath of some disaster such as an air crash. We need to get much better at it. We need to provide support for the victims, and we need to draw them in and give them a clear understanding of what's happened, be honest and frank at the outset, and then provide them with all the support that they need to overcome their tragic loss.
There's no question that patients ought to have as a very basic right that they ought to feel safe in a hospital, that they ought to not have to worry about will they get the wrong medications or will the wrong treatment be given. Given all the worries that they have, that seems like a very baseline promise we ought to be able to keep.
First of all, do no harm. That means that patient safety is at the crux of all that nursing does. It's about creating a safe place for patients to heal, That means a safe environment, but it's also about getting the right care at the right time from the right person, making sure that that care is given in a quality way to patients. Needle injuries are a big major issue for us, especially with blood-borne diseases that are around. And then in addition to that, back injuries are also a major issue for nurses. There's a lot of nurses who end up retiring early on sick leave and because they've had an injury and they're no longer able to function in the work environment.
The major disasters that we all see in our hospitals rarely ever come from major events. They come from perhaps poor communication, they come from a doctor being too tired, they come from a team not getting together and discussing the very sick patients adequately. They perhaps come from the wrong measurement being taken. It's a lot of little things that each one on their own wouldn't have mattered, but perhaps in this particular patient, they're going to lead down an inexorable road that will lead to a catastrophic event.
Why would we have error rates at that rate in systems that were ostensibly there to treat sick patients?
How can we begin to tackle this huge problem of medical error? What is it that doctors and nurses and clinical teams can start doing tomorrow to improve the situation?
The 5 most dangerous words that we could possibly hear in a hospital are, "It could not happen here," because that would suggest that people just really don't appreciate how high risk their environment is, and they aren't worrying about the safety of care provided, and they're suffering from the sort of complacency that in the end makes healthcare much more unsafe.
Some organisations and circumstances are like this, highly vulnerable to error. Others have some measure of resistance. The aim is to reach this position, where resistance to error is part of normal life. So what needs to be done?
The first is to be alarmed, to really see the problem for what it is, and to be alarmed by it, so that our will is galvanized.
Everybody in the hospital needs to eat, breathe, sleep, and act safely at every time and every opportunity they can.
If there was one simple solution, if there was a magic bullet, something simple we could do to sort everything out, that would be fine. What research is showing us that the safety is a complex business. It's fluid, dynamic, changing.
One of the things that we have to do is to move from an abstract analysis, once we are quite sure that we have a framework for operation, and then move immediately to begin to engage with all the communities who can, as it were, breathe substance into that framework, make it work, make it real in terms of their experience.
Are there system faults that have actually led somebody to an error? Is the team makeup right? Is the actual skill mix of the team and the knowledge base of the team around the consultant actually, has that been right? Are there other things outside our jurisdiction really that we need to address?
Safety is a form of reliability. If work relies on human memory, for example, we know it'll be unreliable. Human memory is frail. It's a human factor. It's inevitable. It's not a matter of will or goodwill or intentions. We forget things. I mix up the names of my own children, as all fathers do. So if it's important that we be reliable about remembering things, we can't rely on human memory. We have to have supports. So that's an example of design. We would design into a system supports for work that make it unnecessary to memorize things.
We won't make changes to large numbers of staff overnight, and therefore this is a long-term developmental process rather than an add-on that can be dealt with by meeting a few targets. It's something which is fundamental to the way in which we deliver healthcare.
A relentless spirit of inquiry, curiosity, and habits of excellence in pursuit of improving this problem, so that you would never be satisfied. You'd always be looking for who might be doing it better.
Well, it means coordination and collaboration, and nurses do it almost effortlessly. It's amazing. We're frequently called the glue of the hospital, but it's invisible because all the things that nurses are doing frequently are unnoticed.
Information about errors and adverse events, harmful outcomes in healthcare has very seldom been studied openly. It's been treated as a nuisance, something we don't want to know about, an occasion for shame, guilt, and other sorts of problems. In the last few years in healthcare, we've come to realise that it can also be, if treated properly, a resource and an essential way of achieving a safe culture and of promoting safety.
There is a problem of balance between two aspects of seeking safety. The aspects are technical and cultural. Like everyone else, I wish there were a quick fix. It'd be nice to buy a computer, install it, and then we're safe.
We have a terrific problem with technology. It will not fix the problems we have. We truly believe that technology should be an enabler that enables better or best practice. And then the technologies, products, and services that can enable that practice need to be utilized. Culture is absolutely critical when we take that approach.
I wish I could move the balance a little bit more now from the technical quick fix to the idea we need to look at our cultures, our assumptions, our norms, and our behaviors and change those, or else the technology is not going to help us.
The secret of quality is love. Where someone truly loves his or her job, those people are the ones that excel. Those are the ones that dedicate themselves to improving the quality. Those are the ones who dedicate themselves in reaching those goals that are way out there, but yet we think they're unattainable and that they're being attained. We need to learn how to harness that so that we can fix the quality in our systems.
It's a devastating and harrowing experience for a clinical team to lose a patient, and lose a patient through an error that's potentially avoidable.
The doctor who phoned in tears because he'd accidentally killed a baby that morning and needed comfort. And when he said he was going to go and tell the family that he'd accidentally killed their baby that morning because he'd heard us speak and openness is the best policy, he came back on the phone later distressed because when he told them the truth, they sat and cuddled him and said, "How terrible for you and how terrible for us."
Talking to clinicians of all kinds about the events they carry around with them, about the things they were involved in, what happened to them. If you're a psychologist or a psychiatrist, as I am, it's the suicides. People remember the people who committed suicide under their care, and there's an equivalent for whatever branch of medicine you're in, the mistakes, the blunders, the awful thing that's happened.
The basic mechanism, I believe, lives in the world of human factors. And it's not as if human factors hasn't been applied to other industries. It has. I mean, human factors was applied spectacularly to the nuclear power industry after the 3 Mile Island disaster. It's been applied to the chemical industry after the Bhopal disaster. Human factors have played a major role in improving aviation safety. Well, taking that whole field and applying it to healthcare is something that we've now just begun to do, and we've started to do it 20 to 30 years after those other industries.
We need to decide to be safe. We need to understand that the defect rates we have today are neither acceptable nor inevitable.
More than that is the sense of the dis-ease and sense of the possibility of harming a patient. It doesn't leave you when you leave the hospital that day.
Great doctors are not the ones that never make errors. Rather, they are people who expect errors to happen and who have strategies in place to cope with them before these adverse events could cause harm to a patient.
We're talking about a very fundamental change in the way we do business in healthcare, the way we've always done it. And change of any kind is difficult. This change of this magnitude is really very difficult, and I think that's what we're trying to do. We're trying to bring about a revolution in the way we think about, not just about what we do, but really in a sense, the way we think about ourselves.